All right, man. I know we talked a little bit before, but like, I know you work with Derek Hansen, work familiar with Bill Hartman stuff. Learn a lot from Gordon. We both learn a lot from Gordon and Stu McMillan. But like, still, kind of like introduce yourself a little bit.
Yeah, well, thanks for having me, Eric. It was a lot of back and forth to organize it, but I'm glad we made it. So my name's Jordan. I'm a physiotherapist in Montreal, Canada. I guess to make it short, like you said, I work a lot with track and field. I got introduced to that initially through Stuart McMillan, through Altus. I've spent quite a bit of time learning from them. So I started with a performance therapy program with Jerry Ramajita. Then I went back for a few months and learned a lot from Jazz Randawa, was their medical lead at the time, and then started to work with. I guess that exposed me to a lot of stuff actually. Like I was always very curious. I learned from a lot of people. I was already doing a lot of learning from Zach Couples at the time. And then kind of, transition towards some of Bill's stuff as well, as you said, and then start to work with bobsled. So with Bobsled Skeleton Canada, I worked with them for basically the quad before the Beijing Olympics and then a few years after. And then around the same time, started to work a lot with track locally here. And so that's where I had reached out to Derek initially to learn some EMS stuff. And then he came to teach where I work. So I rent space out of a small gym here in Montreal. So he came to teach and got to learn a bit his approach. And it's just been kind of like accumulating, information and different perspectives, different tools, and kind of making my own thing out of that. Um, so currently, I work with a lot of tracks, so a lot of sprinters, a lot of mid-distance runners, um, and then a few jumpers, a few hurdlers. Um, that's roughly it track-wise. I work a lot with diving too, actually, and a lot also with Olympic weightlifting, and then with other sports. So I still do some stuff with bobsleigh, hockey, of course, we're in Montreal, rugby, things like that. But I'd say like the ones that I see like a lot of people love would definitely be track, diving, relatively, weightlifting as well, would probably be the main ones. So yeah, that's roughly it.
Nice, nice. So, since probably you work with all kinds of sport, can you kind of like, I know this is a big one, but just can you kind of walk me through that? Let's say if an athlete come to you, what's your like maybe like your movement assessment or like your thought process of or your approach to like a new athlete?
To a new athlete. I work off of, and I tell that to the athletes that I work with. I work with a lot of like information. I gather a lot of information. I like to have a lot of information, and because simply you never know what can be useful. Um, I think it depends also on like let's say what I'm hired to do, but I would say in either case that doesn't really change. And in all cases, I'll ask a lot of information beforehand. So obviously, like what's been going on, previous injuries, who have you been working with before, what have you done? I see a lot of people that have been struggling with issues for a long time, and so I always find that useful to see what have they done, what worked, but not for not with a lasting change, what didn't work. I find that information to be very useful. And then when I can, I'll try to talk also, if I can talk to previous therapists, if I can talk to coaches, I will usually reach out as well and kind of get their perspective. And then from there, it kind of depends on what I have to do, right? So if it's more of a, let's say, like a rehab, return to play situation versus if it's there's some issues that we need to manage, but they're, more optimization versus, you know, there's an injury like a hamstring pull, but like so it kind of varies on what I have in terms of what part will I play, basically. How many like what hats do I wear? So, if it's more of a rehab based patient, so like after an ACL, and I'll be the one managing, the training load, then that will be very, very different to an extent, in the sense that obviously I'll do more. more performance testing with, force plates and things like that. Maybe some Moxie, like I think I mentioned to you, like I've been also messing around with some Omega Wave stuff. Um, I wouldn't do that with someone with who I need to manage, let's say, a groin pull or some weird mechanics that occur and that they're not, sure what to do. I will go get that information. I just don't find that like from the get-go it's as useful. Um, I'm fortunate to manage my schedule the way that I want. So if I want to have more time with people, I can usually organize that. Um, so that's kind of neat if I need to do more testing. But generally speaking, once I have that base information, I'll usually look at a lot of video if I can. I like to have video from a lot of different angles. That's definitely something that I've taken from from Altus, from Stu, from Dan, from Jazz, simply because um, it's very simple to see that like with one angle you just can't get all the information, right? You can get very easily misled, and also getting more reps. I'm very skeptical by nature too, so I think like if you show me one video and you say, we see this and this means whatever, I don't buy it. Like I need to have like multiple videos and proof that that's an issue, because it's very complex. So I don't think we can just say, here's one thing, the athlete did X, so we need to manipulate their thoracic spine, right? Like at least in my mind, I'm not good enough to be able to say that. So I'll look a lot of video, I'll talk to the person and see, what's going on. Obviously. And then from there, usually my movement assessment is, in terms of, let's say, testing that I do, is relatively simple. I find that doing some table testing of range of motion, which I guess was very influenced from Zach and Bill in that regard, I think is very useful, to give me an idea of where things sit, right? So looking at how the person is made, morphology, Bill and Zach both talk a lot about the infrasternal angle. It's something that I look at. I will say that it's still something that I'm kind of wrapping my head around where it fits, but I do find that it's a useful thing to look at. I'll look at that. I'll look at ranges of motion too. I'll basically always do shoulder, hips in all directions pretty much. And then depending on the issue, so obviously with, a lot of sprinters, um, I'll look at, knee and tibial rotation, ankle, hind, like rear foot, hind foot, same thing, sorry, rear foot, midfoot, forefoot, toes. I'll look at all of that usually. And it kind of depends. I won't always go to the toes, but typically I'll always kind of have an idea of how that moves. Um, I have been also doing a little bit more of the like sacrum assessments, SI assessments, a la Gordon. Those are tests that I've always been kind of, I've seen them for such a long time and I was never really sure of what I was looking at. So I decided to, that's something that Zach had told me way back when, and he had said, just assess, like just do the test. You don't have to do anything about it, but just do the test and then retest and see if something changes. I had done that initially with some table testing, and I'm kind of doing that also with the SI now. So I'm still wrapping my head around part of it. Um, I don't think that I'm as good as Gordon to be very reliable with what I'm doing sometimes. So I'll usually try to like look at, okay, well, what do my table tests tell me with regards to the person's position? What do the, standing tests tell me? What does the video tell me? What are the symptoms if there are symptoms? And then I'll kind of do like a bit of like a cross of all that to say, okay, what do we need to intervene on? And then, once that's done, I'll usually look at movement in whatever the movement is. So, if it's a weightlifter, snatch, clean and jerk, I'll usually look at a few variations. That is a little bit of like I guess, an SFMA type of mindset for me, in the sense that um, how does it cross-reference with everything else? So I have an issue in a split jerk. I don't have an issue in a push jerk. Okay, well, maybe there's something going on with the lower extremity, or like spine and down. I have an issue when I power snatch, not when I like basically just kind of trying to eliminate things. And then um, I'll do a lot of test retest, so I'll, as much as possible, I'll try to do a few things once I intervene, and then just kind of go back and forth and see how these things change. So that's roughly my movement assessment. Like I'll throw in a few more general things sometimes. I've been adding in some Well, it's not really added in. It's more maybe looking at different elements. So in like a body torque test or like a multi-segmental rotation test, um, I'll always look at like the general motion, but I'll also have a little bit more of a look at, let's say, the actual foot motion. So how the foot rotates, right? So as they rotate to the right, well, how does the right foot supinate, for instance, compared to the left when you go to the left? And then looking at like a split stance, just getting the knee over the foot, seeing how the arch drops or doesn't. Those are some like anatomy and motion type of tests that I kind of like to give me like a bit of an idea of how the foot is moving as well, and that in weight bearing, right? Um, so that's generally it. It's pretty like I would say that that's kind of the core stuff that I'll do, and then the rest is variable depending on the complaint, depending on who I'm dealing with, the sport that I'm dealing with. You know, if it's a groin issue, I'll do some groin testing and whatnot, right? But I'd say that that's roughly it. I really like to see people move. I like to be on the track when I can. So I do that about once a week with a group that I work with. I like to, I work out of in a gym, so I have space. I can have people lift if I want. I can have people, you know, do skips, excels, whatever. I've been doing a lot more skipping. That's also influenced by Stu. So just like very easy, light and relaxed skipping, stuff like that. So, so yeah, that I would say that that's roughly it.
Nice, nice, nice. So I know I probably already answered this in a way, but like Gordon, he's like a pelvis guy. Everything starts from the pelvis. Me, I probably say pelvis or the spine. Like I mentioned, I like to look at the pelvis. I like to look at the spine if there's scoliosis or not. I know like we mentioned, like there are guys like like to start from the foot.
The feet people.
So for you personally, like would you say like or there's some guy who wants to look at like shoulder, whatever. For you, what would you start? Where would you start?
There's the neck people too, right? There's
Yeah,
the eye
yeah,
people, the
yeah.
neck people. Well, I think it depends on the relationship I have with the athlete. I think sometimes we go a bit too big picture. You know, it's a little bit like the forest and tree thing, right? Like it's good to look at the forest, but then we should also look at the individual trees. I've seen a lot of things that were like knee issues, right? I remember it, especially from like SFMA, let's say, or even in school, we're taught like look at the joint above and below, and I've seen knee issues that people were like hammering on the ankle and the hip, and it was like no, it was like the knee needed attention, you know. So I think that depending on who the person is, if it's someone that I'm starting to work with and who's not very familiar with me, I'm not gonna go hyper like super funky from the beginning, funky for what they might think, right? I'm gonna go. Oh, I think I always pay attention locally to what's going on, to the tissues locally. Um, One thing that I would say picked up from spending time with jazz, especially when I was at Altus. Uh, how many years ago was it now? 8 years ago, I think, was the time I was there for longer. Was just being more precise and more precise with anatomy, more precise with the tissues that I have under my hand. And I would say that looking at Chris Clatcham, who's a car from Toronto, he also should have a master class on the Alta stuff soonish. He's also, I find, very much like that. And I don't think it's always necessary to be like perfectly spot on with the anatomy, but I think that it's helpful, and I think that the more we can be precise, I do a lot of dry needling, and with that, obviously, like precision is very important. And all of that to say, I think that having an idea of what the structures are allows us sometimes to be able to pinpoint and address those issues a little bit better. And so, going back to your question, I will always have a detailed attention to the area of symptoms to try to figure out what's going on. And then from there, depending again on who the person is, I might start with something a little bit more local. And usually I'll also give them something a bit more global, but I'll kind of dose it. I'll put a little bit less of it. So I might think that the issue is a um, general, movement options problem, and they need to change the way that they move. They need to shift maybe their weight in certain areas, or they need to access certain motions that they don't have that has, for them, nothing to do with the painful area. So let's say like I work actually a decent amount with baseball as well. Someone with a shoulder issue, and now we start addressing, the pelvis, the foot contacts. Like that might be pretty funky, especially for like a younger pitcher who isn't familiar with that. So I'll usually start with, something local, whatever the area is painful, right? I'll always try to incorporate that into what we're doing, and then I'll do something a little bit more global. I usually, if I have to say, like, I would normally pretty start with, I would call it like a ventral cavity or like a trunk thing, right? So I'll look at kind of, from the chin down to the coccyx. That's going to be the first thing that I'll look at normally, and then kind of go out, unless there's, something crazy going on at the feet, and then I might start there in those cases. But I'll usually start at the trunk. So, and that's a bit vague still because the trunk incorporates, the pelvis, the sacrum, the rib cage, but it's my cop out answer. So for someone who's I know better and who I might, already, they kind of know how I work and they're a little bit more bought into that process. I'll sometimes straight up go there and be like, no, we don't need to do whatever to your shoulder. Just like leave it alone, and let's just focus on the rest.
Nice. Nice.
That's usually where I would start. And I do kind of the same when I treat, I would say, like even on the track. I will usually start in those areas and then work out from there, typically, I would say.
Nice. Nice. Nice.
Yeah.
So, um, since you brought up like groin pain, and recently, like I kind of have like issue with groin pain because, man, this podcast kind of like how I grow. Like years ago when I have like issue with like shoulder pain, I'll ask people about shoulder pain. Like last year started, I figured like even when I use SFMA, there's still gonna be something going on with their low back, with their hip, with their abdomen. I just can't figure that out. Then I go to people, ask about SI joint, learn about SI, do the what's that called? Kinetic control from UK, a movement assessment from UK. Did the kinetic control, and then reach out to people who are familiar with SI. Now, like growing pain kind of bothers me, and you also mentioned that. So, can you kind of walk me through that, your thought process on like treating like athletes who have growing pain? Since like you also work with like track athletes.
Growing pain's complicated, man. There's a few very good resources so there was like a Doha agreement a few years ago on groin pain. I don't know if you're familiar with that one. Obviously there's Enda King, who's in the UK, who's like a pretty interesting person to talk to about that. And like, he works with Aspertar as well, or he was working. I don't know if he's still there, but they have like a bunch of info on that. So if you want to, dive deep into that, you can. But I think that the bottom line of a lot of those things is that the groin area is just so busy. And that's, well, again, going back to Jazz for me. Like I remember talking to Jazz about that, and we were just looking at all the anatomy that's going through the pubic symphysis, looking at all the stuff that is attaching there, and the attachments that really aren't, like, it's not like a clean attachment, right? They wrap around, they loop through, there's fascia going through it, there's nerves going through it. Um, it's a really complicated area. And so when you look at um, trying to be, again, precise with the anatomy, I think that can be helpful to be able to discern certain areas in terms of what type of therapies you want to do there. I think another interesting thing that comes out while looking at some of the research is that it doesn't always matter what's going on. Like, you need to discern if you need surgery or not. I guess that's kind of an important, obviously important element. But if you don't need surgery, in a lot of cases, actually, Neki, you kind of need similar things, and the anatomy doesn't matter as much, which is might seem, I guess, counter to what I was saying earlier, but to me, like, those two things can coexist, right? In some cases is very important. And I want to know what anatomy I'm on if I'm doing manual therapy, needling, or whatever, and have a precise idea what I'm trying to target. Even though, again, when you look at some of the research, the return to play can be quite similar regardless of region. Um, One thing that I've noticed is again, there's a lot of focus on the groin, right? Which is kind of a dumb thing to say, but meaning that people will do a lot of, you know, adductor squeezes, isometrics, stretching their adductors, dead bugs, banded, hip flexor work. That's usually how people address these areas. And I think that one thing that's often missed is going back to what we were saying earlier, what's the position of of the pelvis? I think that some of the concepts to me that let's say that I've gotten from Zach a lot and from Bill are very useful there because I've seen a lot of cases in which you can contract all you want if the position of the pelvis is putting that area in a lengthened position, however we want to call that otherwise, in a position where the symptomatic tissue is under constant tension, then we're not helping that at all. And we're just adding tension to the problem, which can sometimes lead to further injury, but also it's already loaded, right? We need to offload it. And so um, the pelvic positioning, oftentimes anterior pelvic tilt type of issue, similar to a hamstring issue. So control of the lumbopelvic region of the ventral cavity, like that's super, super, super important to me. Making sure that you have the range of motion through there. Because whenever you're going to move the hip, if there's restrictions in motion, well, that restriction is going to get in, going to go through the pelvis and the pubic symphysis. So I think being able to look at if that's moving properly is huge. Um, that I think is one really big thing that I've noticed with a lot of cases where the issue persists. And then the other thing too is that especially if it's like an insertional thing, a lot of insertional problems, whether it's tendinopathies, enthesopathies, whatever, they once they get irritated, like they get very irritated. I often compare it to a fire, right? So like the fire takes time to start. It doesn't, start right of a sudden, right? Typically, if we're talking about overuse, which is oftentimes the case, it will build up, right? It's the right environment for the fire, right? So there might be some limitations in motion. There might be, anterior pelvic tilt. There might be probably some genetic elements, maybe lack of strength. And then you add on top of it a bunch of training load that might be mismanaged, but might also sometimes be okay. But because of the lack of movement, we end up with focal loads in that area specifically. And then that's kind of the spark, right? And so everything was present. The spark just lit it up. And once it's on fire, quote unquote, it's actually very hard to make it die down. And I think that's one element that when I started practicing, I was trying to avoid that. So I was trying to avoid the offloading piece. And I think that I was sometimes just not having good results or just dragging onto things because they needed to be, you kind of needed to like, kill the fire, right? So you can change the environment. So we can say that now your hips are moving fine, your pelvis is in a better position because that's an ongoing issue, ongoing work. It's not something you just do once and it's done. But the fire is still going and still needs to die down, right? So even if I take away the elements that are feeding it, it's still going to take some time to go down. And so I think that element you need to kind of look at, okay, well, technically, is there anything that's going on, whether it's a change of direction that's causing the problem, whether it's acceleration mechanics, whether it's a jumper with, some adductor issues, um, looking at the movement and then seeing, well, one, is there something else in the kinetic chain that's a problem? And then all bets are off, right? It could be through the foot, it can be the SI, it can be the rib cage. So are there other things we need to address first off to make sure that we have good distribution of the load? And then at the same time, do we need to modify technically something or do we need to modify something in the training menu? So going back to what I was saying, I'll communicate a lot with the coaches and I've seen I haven't seen nearly as much as Stu or some of these other guys, but I have seen quite a few people move, and so I'm able sometimes to pick up on some stuff, and I'll talk to the coach and I'll say, hey, what do you think? Like, what do you think about this? Like, how do you find his acceleration mechanics? How do you find his what he's doing when he's pushing in the Excel? And then sometimes we'll say, okay, well, are you okay with us trying to modify something here or to so sometimes it's modifying and then we modify and we end up with less symptoms or sometimes it needs to be what maybe we just need to cut the max V work for a short period of time because we're maintaining it and we're irritating it all the time, like on, 3 times per week or whatever. 3 times per week for Magazine is a bit a lot, but whenever they're doing it. So we sometimes need to pull back the reins to say, let's kill the fire. The mechanics are better. As the fire goes away, the mechanics should also improve because now there's no inhibition because of the pain. And then we can reintegrate, and hopefully the person is moving better at that same time. So long-winded answer to, like, I think the trunk element is really important. I think the mechanics of the rest of the body are really important because when we look at, let's say, change of direction, um, technique or mechanics again, there are certain types of ways that people will cut that is more prevalent in people with groin pain and groin issues. So we need to modify that, right? And again, it's complex. It's not as easy as saying like, oh, well, this is the only thing, and we change it. But I think that it gives us different pathways that we can address the issue, right? So if the person has a tendency to cross over a lot, maybe we need to teach them to do a little bit more of a hip turn or repositioning their feet a little bit better, so that they can push off without having to cross, for instance. So that's kind of usually how I'll address it. I'll see how much can we get by just modifying elements and then improving how things move. Otherwise, I'll see if we need to cut things down. And then in terms of the modifying and in terms of, like, let's say the treatment element, um, once things are moving okay and we can, get the SI to move, get the rest of the kinetic chain to move, uh, we might need some work through the area too. So I think some different variations of like dry needling or needling, even with stem, can be quite useful. Um, Chris is like masterful at that. I've picked up stuff from him a lot, and then also from the way that I, let's say, needle originally. I think that that can be an interesting thing to look at. Um, in other cases, we also need to look at, is there some sort of nerve problem, right? So is there a compression, like an L2 compression or something like that, which would take us away from the groin pain, or the groin pathology, let's say, but look at more differential diagnosis. What else can it be? And then going back to what we were saying, I'll sometimes throw a little something and see how it responds. So, maybe I'll needle at L2 and see, am I creating a change? Do I get a reduction in symptoms? Um, or is there something else going along that dermatome or myotome or that level, for instance? Mm, that's roughly what comes to mind.
Nice, nice. You kind of like brought up tendinopathy. So like in the past few years, whenever like people talk about tendinopathy, tendinosis, whatever, they always think about like isometric. Like it's like isometric is a cure for tendinopathy. So uh can you kind of share your thoughts on like isometric and tendinopathy?
Um, there have definitely been, I think there's like trends, right? Also with those type of things. So the trend was eccentric load, right? Alfredson, I think that's his name, protocol. Have you ever seen that for the Achilles? It's like 1,000 reps of like heel drops. Um, Apparently the guy actually the goal was he had a lot of pain in his Achilles, and so he had gone to the doctor, and doctor said like nothing to do unless it's torn, and he was trying to tear his Achilles by doing like sets of 25 eccentric lowerings, right? And then ended up fixing his Achilles problem, so he didn't need the surgery. But that was like a big trend, and that's still pretty prevalent. Like if you see a lot of physios will still prescribe eccentric work. I think ultimately when you look at a lot of the data, you need something typically that is slow load, and you need load, right? Um, Isometric is very slow. Obviously, it's as slow as it can get, right? So the muscle's contracting, the tendon is slowly creeping and kind of allowing itself to get pulled. Um, I think that when we look at lower limb, so like patellar tendon, Achilles, most of the research comes from the lower limb research. If you look at upper body, it's actually it's pretty tricky. It's a lot more spotty, like doing like isometrics for like a wrist extensor, like a tennis elbow type of situation, isn't something that you see a lot. And then there's also like the FRC people that they will do. And I say that I did FRC like 11 years ago. But you'll see a lot of, oh, that hurts. We need to load it isometrically, right? We need to do pels and rails or what have you. So I think that that's, at least from my perspective, that's where I've seen those different perspectives and a lot of like isometric work come from. Um, what do I think about it? I think that it can be an easy way to load something. And there is research that shows that there's a certain analgesic effect, which I think is beneficial. And also to get some sort of change, which is the other thing. So like analgesia is fine and it's important to have, but we want a long-term effect, right? And so the long-term effect will come with you need an adaptation. So you need a load that's sufficient. And that's the first thing where I think we don't load enough. And we need a volume, right? We need it's like strength training, right? So if I want to increase my squat, doing I don't know a set of 10 with a random weight like isn't going to make it, right? I need to load my body and stress my body in a way that will lead to an adaptation. And with a lot of isometric work, I think we get stuck on the light light load long isometric. So I do think it's useful. I don't think it needs to be ISO. I think that sometimes people are just very irritated. And so if you have a lot of irritation in an area and we're putting it in a position where you're putting a lot of compression through the tendon, or you're creating a lot of tension through the nerves around the tendon, that can cause more sensitivity. And so we try to avoid that. So it needs to be a gradual process. I think the ISOs are kind of a start, right? So I have an athlete right now doing some isometrics in a split squat before her training sessions. And it's a start, right? It's a way to start loading it. She's not someone who is very um, trained. She hasn't done a lot of strength training, or at least not recently. And it's an easy way to say, let's do that. Very simple to do. You don't need a lot of equipment. Let's just start with that. But that can't be the end, right? Then we need to look at, okay, training program wise, what do we need to look at also in terms of mechanics so that we can see, like, is there always tension on the tendon? Do we need to reduce the tension on the tendon through working on improving mechanics? And then we incorporate more load through the tendon because we want the adaptation on the tendon itself. And and that's ultimately what the goal is. I think in the short term, we're creating that tension through the tendon. We're potentially pushing, liquid out of the tendon, which is helping with the function of it. And we're also doing something different. So let's say if we talk about, again, runners, middle distance runners who do, they run a lot, obviously, and at pretty good speeds. And then they also do some plyos and stuff like that. They do a lot of quick tendon load, right? So like very abrupt load through the tendon. If you look at like some of Keith Barr's stuff, like what he was showing was that, well, the plyo type of work will load the tendon, but it will create a little bit more stiffness over time as opposed to doing something with slower load, which is going to create a little bit more malleability through it. So that I think goes back to like that spectrum of I want the tension and the performance, but I also need the health of the tissue. And if it's too rigid, like anything in our body and most systems in our body, if there's too much rigidity, it's not healthy. So I think the ISOs are an easy way to start that. I think that oftentimes we don't load enough. Some of Alex Natera's stuff that he was showing with like the run specific ISOs, I think is a useful way to look at it too, because there's kind of a progression that you can look at there as well. So going from, isometric to potentially some drop in catches, or some isotonic work, I think can be very useful. So I don't think the isometrics are special. I think they're easy to do. They're easy to standardize. So I can easily tell you, I want you to do this ISO at 45 degrees of knee extension, and you can do that pretty easily. So it's easier to control. When it comes to upper body, I think it's a way to create some blood flow in the area, right? Initial stages of if there's some sort of injury, we can use that to start loading. But again, in terms of like research, it's really not as clear that it's that beneficial. So to me, it's a beginning. That's usually how I'll see the isometric work. A beginning or a way to manage symptoms, and then from there we progress.
Nice, nice, nice. So,
Sorry to cut you off. Like the groin thing would be the same, right? Like, so I'll see a lot of like going back to like the groin squeeze, right? Like, what are your exercises that you've been doing? I put a ball between my knees and I squeeze. And what does it do? Well, it hurts. okay, well, that might be something that can be useful, but if the position of the tendon isn't adequate, we think about it when we think about an Achilles, right? When you start someone with an Achilles, you're not going to start him in a massive deficit, like super stretched through the Achilles. Like, that would be a bad idea. But because at the groin, to go back to that, we don't see it as easily. You don't see the tendon being pulled on the pubic symphysis. So it's easier to say, whatever, just squeeze that ball and shut up, right? So I think that the positioning is really, really important.
Nice, nice, nice. That's like pretty cool. Like you kind of like explain it very thorough. I like it. So I guess I guess my next question would be like, because after these like conversation, like I feel like your approach to like athlete or kind, it's very like, what's the word I'm looking for? It's very individualized,
Okay.
if I'm understanding it correct.
I try.
Yeah. So, um, I guess my question would be like, so you work with or you learn with so many like great coaches, great therapists. So I guess like we mentioned, what's the biggest takeaway from Derek Hansen and what's the biggest takeaway from like uh Jerry? What's the biggest takeaway from like Gordon?
Well, okay, so to be fair, I haven't learned as much from Jerry as I have um I guess you could say from Derek. And those three, Derek is definitely the person I've learned the most from. And then I guess it would be Gordon and Jerry. I've done some learning from, I guess, indirectly from him through jazz as well. But it's weird to think of it that way.
Because I
I
know
think that
at the beginning I sent you another question, but I feel like it's just gonna throw everything up like all well, like it's just gonna be a mess. So
um, I'll maybe like I'll try to maybe make like a bit of a mix. Is that okay? Instead of doing
yeah,
it
sure,
perfect.
sure, sure, sure.
But I think for Derek, it's kind of easy. Well, easy because I think that one of the things I've taken from Derek is like sometimes simple works very well. And I think you can do something simple that is just very like there's a lot of thought behind it, and there's a lot of things that you address through this one simple solution. And I think he is very good at that. And he has, years of experience and analysis and looking at those things. And I think that that's where I don't have that, right? Similarly to Gordon. So sometimes I can look at something that they do, and I would like to be able to do that and, kind of, hit it out of the park. Uh, but I just don't have the experience and the pattern recognition to be able to like press the right button. Bill is exceptional like that too, right? So Bill will look at something and he'll ask a few things and you'd be like, okay, like, we probably should start there. And he might be wrong sometimes, the same as Derek and Gordon, right? No one's perfect. But I think that when you look at that, it's really cool. And that's obviously what we all strive to develop is this mastery to the point where like you get it wrong less often, right? And you need less stuff to see the pattern. Um, I think that's something that I've seen from Derek. His approach is super simple, but it can be so effective,
Yeah.
right? So I think keeping things as close as possible to the main activity when we're bringing someone back or when someone's injured, that would also be something that, from Dan and from Stu, keeping plan B as close to plan A as possible, right? Minimizing training gaps. I think that's something that is very important for me. It's very easy to say, I have this injury, I can't do anything, right? And there's just so many things that you can do and it's fascinating to see how much better and how much you can improve yourself by doing that as opposed to taking the I can't sprint full out, I can't lift full out, so I'm not going to do anything or I'll be very far from that. I'm gonna just do GPP and I'm just going to like it's like well no maybe there's something we can do a little bit more of a bridge here, right? And I think that goes back to like if we can specifically know what the issue is then it's easier to do that. And so that is, I think, a very important element for me. Also looking at things and I think realizing that the human body is complex, right? Stu talks a lot about that. I picked that up initially. There was a conference in Boston that Art Horn was hosting. It was the BSMPG, which I think everyone who has been is sad that he hasn't done it recently since he started in the NBA. But he had brought a dude. Who was it? Was it Mike Green? And he was talking about the Kinevin framework. You're familiar with that?
No.
Simple, complicated, complex, chaotic. Um, Bill talks often about it. Stu talks often about it. Um, this framework is a framework that comes from economics, I think. And basically, it kind of divides different types of um, processes, environments. I guess you can place it under different words. So the simple being an obvious, you do one thing happens. It's easy to see, it's easy to analyze. Complicated is a long string of things, right? So that would be something more like mechanics. So if I do one thing here, I can follow and predict what's going to happen after 20 steps, let's say. Complex would be a human organism, an ecosystem, in which you have a lot of different things that interact into the system. And so when you change one thing, you don't know what happens. You don't know which way it's going to go because it's uncertain. And then chaotic is chaotic. You can't predict. You need to like there's no way to really know because there's just too many things going everywhere. And basically, depending on where we are, we have to act in different ways. If we go back to the complex part, which I think is where we operate most of the time, because we can't predict, and I think that that's one error that a lot of times we do when it comes to, injury prevention, for instance, or things like that, is that, well, you need to do something, you need to intervene in a safe to fail way, in a way that isn't harmful for the person. And then you kind of see, well, what did that do? Right. So I think that that's something that Gordon does very well without stating it that way, but Gordon does that. I know that in Stu's values, that's something that's very important to him. Um, to me, it also came from, well, from Mike, like from seeing it at that conference, also looking at pain is something that's very complex. We can't predict it, right? We don't know if how someone will respond to a certain noxious stimuli or what have you. And I would say that Zach and Bill also will operate in that way. So to me, like that is a very important aspect of what I do in the sense that I can't predict. And so I need to have information to try to educate my decision, do something, and then see what happened. And then I can reiterate on that. So if I had a favorable outcome, I can do more of it. If I didn't have a favorable outcome, I can right away reduce it, right? So that to me is something that also, like as I was telling you, Gordon will put into play a lot. Um, Basically going back to, I think there's an issue here at DSI. Let's intervene. Let's take you off the table. How do you feel? Let's have you move, and so on, right? Um, so I think that those are some takeaways, I guess, just generally from people that I've
Nice, nice.
seen over
And
time.
think, because I talked to like Derek Hansen, I talked to Dan, I talked to Coach Boo Schexnayder, all
Hmm.
these like legendary coaches. I think one thing I learned from them in common is like do the basic stuff like really well. If you're like very good at those just basic stuff, that's good enough. You don't really need to make things complicated. That's the biggest takeaway when I talk to like all like Coach Boo, Dan, and like oh yeah, Derek Hansen.
Hmm. Complicated is always relative, though,
Yeah.
Like, what is complicated? I think depending on what you've done, like if you look at some of the stuff that Derek does with like electrical stim, like that shit's complicated.
Yeah, yeah.
Like it's not simple. Well, to me, it's complicated, right? To him, it's not. But so I think it always like when it always depends through what framework you look at it, right?
Yep.
And I agree. Sometimes it is a question of doing simple things, but I think sometimes we need to isolate something, right? We need to isolate a quality. We need to isolate a tissue. We need to isolate um, a way to improve movement options somewhere, right? And I think that that's where these interventions that look complicated come into play. And I think that the better you get at it. So again, if you look at Zach, if you look at Bill, if you look at Dan when he treats someone, if you look at Gordon, if you look at Chris, like I think that through experience you get better at zoning in and doing something that is simpler. So you can have Bill had his series of like simple solutions, right? Like to get to that, I don't know, doing a variation of a bicep curl for a shoulder issue or for a wrist issue, like to get to that specifically requires quite a bit of thought and analysis to say this is the one thing you need to do. In itself, it's a bicep curl. It's not complicated. It comes with a few cues, okay, but it's not complicated. But to get there, again, from the outside, if you look at it, someone might say, well, that shit's really complicated. But it's all movement. I disagree with the fact that it's like, oh, you just have to squat, bench, and deadlift, do the basics. No, like, why are those the basics? Right? Someone else will say you need to sprint and jump. You need to carry stuff. Okay, whatever. Like, I get it. Like, there's general movement patterns that we should touch on. But at that point, if we want to get into that argument, in my mind, it's more of a question of, well, maybe you should just play. I don't know, like go on a playground, run, jump, climb shit, like throw stuff. If we really like, I think that that to me would be what I would consider maybe the basics. But then there's, logistical and pragmatical things. Like if I go in a park next door and start doing stuff, people would think I'm crazy. Maybe they'll call the cops on me, right? So it's it, that always, I think the perspective of the individual is so important when it comes to that, right? Like going back to the groin pain thing, I don't think we can just, continue squatting and deadlifting with some of those people sometimes. I think that that's not a solution that will fix the problem. And I think that that sometimes is harmful. So looking at, um, and again, that to me comes from people like David Butler and like in the whole pain science world, and also Bill and Zach, I guess we could say, what are the secondary consequences of what we do or of what we say? And the to me, the first time that I started to think about that was through the pain science stuff. You say this thing, you mean X. This is the message you want to make, but your patient understood all of this other stuff too that might now make them fear movement. Well, you fucked up, right? So you need to consider this, right? And Bill will say, we'll talk about that from a mechanical standpoint. Stu will also talk about that, right? Okay, so you're doing this one movement that is simple or whatever because someone decided that it's the basics. And okay, we're gaining leg strength, but you're also maybe creating a problem here. And we need to be aware of that, right? And unless you look, you don't know that there's a problem. I think that that's a really important element to me as well. And again, I don't look at everything. I don't know how to look at everything, and I don't have time to look at everything too sometimes. But just being a little bit more open to what the person says. When you start to look at it from that perspective, whatever the athlete says can be meaningful. Whereas sometimes I think we just dismiss it because we don't think about it that way. We're like, oh, you did the exercise, whatever happened, like, oh, my hips are tighter. Well, no, it can be. The number of times I've heard this, man, like someone saying, a physician or another physio or a strength coach saying, no, 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 this isn't, this has nothing to do with what you just did. And you're like, well, yes, it does. And how do you know? Like, how do you know how this person feels, right? It's ludicrous. So I think I do agree with that, but I think that all of these coaches are also people who've been doing this for so long that they can. I used to laugh with a friend of mine who went to ultrasound with me, like they can see the matrix, like they can see through you, like they see shit that I don't see, and I might get to that point one day, but I'm not there now. So for me to say all you need is this one thing, I don't know what that one thing is. So and I think it's a process. You can't rush it, right? You can't rush mastery. You can't rush experience, right? But I think if you look at more things, it gives you learn more because if you don't look at it, then you don't know. You don't know that it changed, right? So yeah,
Nice, nice. I like it. I like it. It's like very contextual thinking. I like it. I like it.
it's probably Stu.
Good, that's good. So I think that's all the question I have for you today. So for those who are interested in what we're talking about today, where can they reach out to you?
I guess I'm not very active on social media, but I guess it would be like, I don't know, I still have a Facebook or Instagram. It's my name, so Jordan Krouchev, so Iordan, Krouchev, Krouchev. There's probably a few of us, but I don't think there's that many. So I guess that's one way to reach out. I always love to, talk about these things, but I don't post a lot of stuff. I mostly repost like stories and shit. So yeah,
Nice, nice.
yeah.